Conor Hylton was a 26-year-old dental student who was pronounced dead on a TV screen in front of his father. This was in 2024, and Conor presented with nausea, vomiting, abdominal pain, was diagnosed with alcohol-induced pancreatitis, and eventually admitted to the hospital. Unfortunately, he continued to deteriorate with hypotension and worsening mental status, and he was upgraded to the ICU around midnight to 1 in the morning. He continued to deteriorate with seizure, what sounds like aspiration pneumonitis, and then a hypoxic-induced cardiac arrest. Between that time when he ultimately passed away around 4 to 5 in the morning, he was never seen by an ICU physician, and that is because he admitted to an ICU that is covered by Tele ICU overnight. We are all very familiar with telemedicine and the ways that it can extend care to areas or with specialties that hospitals otherwise would not have. And one of those areas also included ICU. And originally it was made because rural areas or remote areas did not have access or the ability to have an in-person physician. So this wasn't a way to extend care. However, one thing to know is that as an ICU doctor, when we are in person, I'm seeing on average 10 to 20 ICU encounters throughout the whole day. Tele-ICU physicians are responsible to cover 100 to 130 patients during their shift across multiple hospital systems. But the part that really bothers me the most about this case, even though there's a lot of things that should bother all of us, is the fact that he was not in a remote area in Montana. Again, like I mentioned, telemedicine can extend care given certain circumstances for certain locations, but in specialties like critical care medicine, in areas where it is densely populated and easy to find a physician, why are we doing tele-ICU?